Hi, this is Comp Cardio, and today we're going to be going over autonomic nervous system regulation of the cardiovascular system. We can consider the nervous system in two parts, as the central and the peripheral nervous system. The central nervous system is composed of the brain and the spinal cord, whereas the peripheral nervous system is composed of these efferent and afferent pathways. If you touch a hot stove, for example, the afferent sensory pathways are going to send the signal up towards your brain that the stove is hot, and then the efferent motor pathways are going to send the signal towards your hands, towards your muscles, to remove your hand from that stove. As far as the motor pathways, there are the somatic and the autonomic pathways. The somatic pathways are voluntary, and autonomic are involuntary movements. In terms of the autonomic nervous system, there's the sympathetic and the parasympathetic system. The sympathetic is responsible for your fight or flight response, whereas the parasympathetic for rest and relaxation, for calming down, for example, after a sympathetic stimulation. Let's consider these pathways. In the somatic nervous system, you have acetylcholine binding to the nicotinic receptor. This is a very fast process, and then that goes towards your skeletal muscle. Actually, all of your pathways have this acetylcholine binding to nicotinic receptors. I remember this was something that came up during class. In your sympathetic nervous system pathways, you have this acetylcholine to nicotinic receptor fast binding, but then you also have norepinephrine or epinephrine binding to your alpha-1, alpha-2, beta-1, beta-2 adrenergic receptors. Alpha-1 and alpha-2 receptors are primarily responsible for vessel constriction, whereas beta-1 and beta-2 I did see are responsible for dilation, for example, bronchodilation, but then we learned in class 2 that they're also responsible for cardiac stimulation. Keep in mind that this binding is G-coupled and a lot slower than your acetylcholine to nicotinic receptor binding. As far as parasympathetic, you have acetylcholine to nicotinic receptor binding, and then you have acetylcholine to muscarinic receptors. And these are also G-coupled binding, but it happens a little bit faster than the sympathetic nervous system binding does. You also have your sympathetic or adrenal going towards acetylcholine and nicotinic receptors, and then that activates adrenal medulla. This is postganglionic, so think, for example, after a kidney transplant, this would be affected. And the adrenal medulla releases about 80% epinephrine and 20% norepinephrine. If we compare the sympathetic and parasympathetic systems, the sympathetic nervous system has thoracolumbar anatomy and is responsible for your fight or flight response. Some of these effects include dilated pupils, dilated bronchioles, so an increase in tidal volume, an increase in heart rate, stroke volume, and contractility of the heart, a decrease in compliance of your veins, adrenaline release, and then stopping of digestion and delayed colon and bladder emptying. On the other hand, parasympathetic responses, keep in mind that these are a lot more fast. They have craniosacral anatomy. They're responsible for rest and recovery. So think constricted pupils, constricted bronchioles, a decreased heart rate, and then promoted digestion and colon and bladder emptying. If you have increased vagal firing, so increased parasympathetic firing, you're going to have a decreased heart rate. And then as the heart rate increases, if we see that on the x-axis, the percent contribution from the sympathetic and vagal stimuli change. So at lower heart rates, you have an increased contribution from your parasympathetic system. And then at higher heart rates, you have increased contribution from your sympathetic nervous system. And then the workload increases with that increased heart rate as well in this case. If you give atropine and propranolol together, your heart rate is ultimately going to go up. So atropine blocks the muscarinic receptors, whereas propranolol is a beta blocker, so that's kind of mimicking or preventing a sympathetic nervous response. So your heart rate would kind of go down, but it goes down slower than it goes up, and it goes down less than it goes up. So you're ultimately going to have a higher heart rate. In the blood vessels, as we covered, there's a lot of sympathetic innervation to the blood vessels, but not as much parasympathetic innervation. So it's going to have a lesser effect on vasculature. Let's also go over the baroreceptor reflex system. If you have a low blood pressure, there's going to be low baroreceptor firing. This is because there's less arterial mole strain. And this system, this lower firing, ultimately acts as a negative feedback loop to maintain your pressure in a healthy range. It serves two purposes. One, if the cardiovascular system starts to fail, this can compensate. And two, this can fix a disturbance. So think back to signals and systems, think back to, for example, an AC system trying to keep your room within a certain temperature. Let's assume that we have a linear time invariant system, just like signals and systems. Here's the block diagram that we end up with. We have an R, a set point, let's call this 100 millimeters of mercury as a normal value, and then your autonomic nervous system. Here's your general CV system. You have a disturbance here, and then your readout is the mean arterial pressure. Then you also have your sensors and the compensation mechanism down here. If you cut over here, your RG is going to equal 0. And then if you cut the system over here, your GH and your RG, or change in RG, are going to equal 0. And this is where you're cutting off your baroreceptor firing. So if you cut the baroreceptors, delta RG equals 0, and you ultimately end up with a bigger change. So in this formula down here, let's pretend that this part gets scratched out. This equals 0. So your change is just due to your disturbance. There's no compensatory mechanism. If you cut the CSP, you can't get a good map reading either. This baroreceptor system has a maximal sensitivity at this optimal value of 100 millimeters of mercury, and then the curve shifts towards the right with chronic hypertension. So the system kind of gets used to the higher pressures, the higher maps. So, and just to keep in mind with this chart, we're comparing the mean arterial pressure and seeing how that factors into the percentage of maximal baroreceptor firing. So we're just trying to get a sense of the sensitivity. There are two kinds of responses that your system can have, a reflexive or an anticipatory response. A reflexive response is to a change in map. So for example, if you stand up really quickly or if you're doing mild exercise, whereas an anticipatory response is going to happen to prevent a change in mean arterial pressure. So for example, in pregnancy or also in exercise. Over here, we can see that GH is essentially the slope of this comparison of the carotid sinus pressure and the arterial pressure. So we had talked a little bit earlier about this cascade effect that happens when you stand up too quickly, for example. Let's go over a case of orthostatic hypotension. So if you stand up, blood is going to pool in your lower body and you're going to have less baroreceptor firing as a result because there's that decreased pressure against the artery walls. As a result, your veins are going to constrict, that compliance is going to go down, your heart rate is going to go up, your cardiac output is going to go up, and then your pressure is also going to go up. And then just to give you a sense of these values, when you're supine, your pressure is higher than when you stand up. Your mean arterial pressure is going to fall at first before the compensatory mechanism kicks in. There's also the case of swimmers having their head down right before they dive into a race. So if your head is down, your carotid sinus pressure would increase, right? Because there's more blood pooling to the head. But racers use this to their advantage in order to trigger an anticipatory baroreflex response. These baroreceptors reduce variability, but not the mean arterial pressure. So that average is going to stay the same, it's just the standard deviation that's going to change. The curve can shift due to hypertension, and then mean arterial pressure increases if baroreceptors are removed, and the firing of the carotid sinus nerve decreases in this case as well. Over time, the change in your pressure is going to be roughly 0 actually. This is due to a combination of hormones and then your circulatory system as a whole. The gain is going to go towards infinity over time. That's all. I hope this was helpful. Thank you for watching.